So apologies for being back up here. Some of you who've been to these meetings, you know that normally in this slot we have well, typically, and they're here today, the binding site. We normally have a talk about free light. Now the binding site has an interesting and important new test called mass spectrometry, but it's not FDA approved yet. So they're not up here talking about it. So I'm up here talking about it because it's still in research. And so the next generation testing is about to be FDA approved. And so next year when we have the seminar, probably we will have official FDA information that's available. And likewise, for decision making, there are a lot of interesting new opportunities of how should you be getting the data? How do you get new knowledge to make the best decisions? And so I'm going to try to lead you through where are we today, but more importantly, where we are going to be within the next year or so. I think there are going to be some major new changes that you need to be ready for. So, next generation testing and decision making. So the good news is that the basics are really unchanged. All the different testing that you get every month or whenever, depending on the cycle of your treatment, all of those basics are mostly unchanged. And so these standard of care testings and the like are mostly under the same as they've been for actually 2-3 decades. Not a lot of that stuff has changed in a long, long time. And so we are, in that sense, ready for some changes. And so the basics of how we approach myeloma are unchanged. And I think that this is the first meeting that Susie has not been at, actually, since the start of the patient seminars. And so she's sorry that she's not here, but her key mantra, knowledge is power, is still the one that we follow. And so the mantra led to the start of the patient and family seminar program about inpatient education. And I was just thinking about it. I'm not sure how many seminars we've actually had in the US since this started, but I'm thinking it must be around about 100 that we've had seminars. And the idea behind that has been that you guys, you need the knowledge to find out what treatment that you should be taking, and how do you monitor if the treatment that you're taking is working? How do you decide if you need to take a new treatment? And you need to be able to get that information. Now, in the US, the family seminar program and the support group programs are very much focused on knowledge is power. But this is the International Myeloma Foundation. And so you need to be aware that actually outside of the US, that's not necessarily the case. That the support groups in other countries are actually focused on support. They're interested in knowledge, but they're interested in yoga. They're interested in things that would help their daily life. One group in Heidelberg in Germany, they focus on painting. They do paintings in their group meetings, and then once a year they have an art show where they display all of the pictures that they painted in the previous year. And so I think for this particular meeting, it's going to be helpful for you to hear from Daryl Tan, who's taken off. He's had a long flight from Singapore. One one of the first support group meetings and PFS meetings that I went to in Singapore, the big focus, which I knew nothing about, was sand painting. And they spent their time talking about sand painting and how this can really be relaxing and helpful. And so I think that we do have that. In fact, we used to have yoga as part of our breakouts. Maybe we need to think about that again. But anyway, for now, we're focused on knowledge. And so I'm going to take you through knowledge, all right? So the key tests that you need are the same. Serum protein electrophoresis. And if you don't get your lab test results from the doctors, mostly you should have the password so that you can get the lab tests. And so this is the one that is most important. And if you look at the bottom, it should tell you what is the size of the spike. Now you'll see here the spike is the one on the right-hand side with the red arrow. That is the spike for the myeloma, and that is the protein that's coming from the myeloma. And what you need to know is what is the level of that protein spike, and is it coming down or going away? And that's the key thing in your test results. And this reflects what's happening in your bone marrow. The other key test for myeloma patients is the bone marrow test, where you can see the number and percentage of the plasma cells in the bone marrow. And this continues to be the basic test. Unfortunately, we don't need to be doing that all the time, because as you see on the left, those myeloma cells are producing those little things, the protein, which comes into the blood and the urine. And so based upon the amount of that protein, which is in the spike, if we go back, those myeloma cells in the bone marrow are producing this spike in your blood. And so when we see the spike coming down, then we know that the bone marrow plasma cells are coming down. Now, the other thing is that in your bone marrow, you'll see at the top on the left, there are normal plasma cells. So that as the myeloma builds up, the normal plasma cells go down. And that's why the normal immunoglobulins go down. And that's why we were talking about using intravenous gamma globulin to compensate for the lower levels of normal immunoglobulins. But the things that are important about myeloma are reflected in the CRAB criteria. I was commenting earlier that we don't see as much of the CRAB criteria anymore. I can't remember the last time that I saw a new patient that was coming because their calcium was increased. That happens when the myeloma is out of control and very active. We don't see that as much. And when was the last time that I saw a patient who was really in total kidney failure? Quite a long time. I do see patients where their kidney testing, the creatinine has gone up a little bit, which is a feature of the myeloma. And then also patients that have some anemia where the hemoglobin has come down. And of course, we do see patients with bone issues where we pick it up on X-ray and possibly on CT, MRI, or PET. And so it's very fortunate that at the top, the MM with the CRAB criteria is less than it used to be. And we're more interested in what we call early active myeloma or high-risk smoldering myeloma, the earlier stages of the disease, where if you start the treatment earlier, and this is true at diagnosis, as I commented earlier, also at relapse, it's good to come in early so that you prevent these different things from happening as best possible. Now, we still do see some patients who have hypercalcemia, kidney failure, and severe anemia, and really major problems from bone damage, but it's much less than it used to be. We still do see patients who are having severe infections, but now that's actually more of an issue related to some of these newer immune therapies or complicated combinations. The basic testing for the FISH testing in the bone marrow and the different imaging is the same that it's been for at least 20, 25 years. So when the bone marrow test is done, it's sent to the pathology lab, and then there is that special staining with the multicolor chromosome picture, which you see on the far left. On the far left, you've got all these different chromosomes which are in the myeloma. This is the chromosomes within the myeloma. So these are genetic changes in the myeloma, which is picked up by the fluorescent in situ hybridization, which is where you give the color to the chromosomes, and you can see if the chromosomes have switched around. And you see, if you see a yellow and a red together, that means because the yellow and the red chromosomes have switched. So it's what we call a translocation. And so by looking at these colored spots between 11 and 14, you can tell that this type of change has happened within the myeloma. And when it's in 11-14, this can help us because there is a particular treatment for that, which we'll be talking about tomorrow. And then as far as the more sophisticated imaging, we've had PET and MRI for at least 20 years. And these are very, very important to show us myeloma, which can be in many, many different parts of the body. And it's important to have a good handle on that. And I certainly recommend either a whole body low dose CT, which can show actual bone destruction, even tiny lesions. And this we've introduced in recent years. In fact, I'd be interested to know, I'll ask two questions. How many people have actually heard of whole body low dose CT? How many people have heard of that? Okay. People have heard of it. Does any patient aware that they ever had it? Oh, this gentleman had one. Okay, so this is an available way to check if you have bone lesions anywhere, and it's more sensitive than taking simple X-rays. Now, in addition to that, I think that the whole body PET CT is very, very good because what you can see in the image in the middle where it says PET, you'll see it has lots of yellow spots. And the yellow spots are where the myeloma is active. And that's where it's taking up the sugar. So you have an injection of sugar, and if the myeloma is active, it takes up the sugar. And you can see it on the PET scan. And so the PET scan is different than the MRI, where it just shows that there's a lesion, which is a white spot. So you can see the white spots where there's myeloma. With the PET, you can see where it's actually actively growing, which is very, very helpful. So how many people have had a PET CT done? Okay, well, that's good to know. You definitely need to be having that done periodically. And then if you have non-secreting myeloma, if the protein level is low and you don't know what's going on, it's very important to have that done. And here recently, it's been in the news because it picks up, and this is important wording to be aware of, extramedullary, EMD for short. And this means that the myeloma is not just in the bone, it's gone into the soft tissues. And this is something that can happen after many different relapses. And this has become very important because it's an indicator that the myeloma is resistant and spreading. And in this case, what is very important, and we're going to talk about tomorrow, we're interested to know if that can be treated with our new therapies. And a study that we'll talk about tomorrow shows, and it's indicated here, is that with a new bispecific combination, a BCMA and a GRC5D combination, the extramedullary disease went away. And so detecting it and then see if this resistant disease is going away is a very, very important thing for the patient, but also for us to learn if a particular combination is going to work when the myeloma is in a more resistant form. So if patients don't have CRAB features, a number of patients who've been started on treatment had what are called myeloma defining events. And those are where the myeloma in the bone marrow is above 60%. So maybe even they don't have any problems, but once you get to this point, it's considered to be a myeloma defining event. Also, if the free light ratio is high, or if, even if patients not having symptoms, pain or the like, if there's more than one lesion on a PET CT scan or a whole body low-dose CT, this is considered to be myeloma, myeloma defining event. And so that should be treated just like myeloma. And so the current approach to myeloma is to look at the spectrum of the disease. And so we know what is active myeloma. Early active myeloma is where you're not having symptoms, but you have high plasma cells in the bone marrow, an elevated free light, or you have more than one lesion that's showing up on specialized scanning. And then the one that's before that is the one in the middle, which is called high-risk smoldering. And if you look at that box in the middle, you can see that it has a mixture of red dots and green dots. And so we want to be able to identify the red dots, which are the patients who are at this early stage, but are in the process of developing active myeloma. So those patients would be the ones who would really, really benefit from early treatment. But we need to make sure that they actually do have this active tendency to develop myeloma. And so the IMF has supported several different projects in this area. One of them is what is called the 2-20-20 system that we did as a collaborative effort with groups all around the world. And what this study showed is that if you look at 3 different tests, it can help you to predict which patient is going to develop myeloma within the next 1 to 2 years. And so those would be the patients who would benefit from early intervention. Now, this is also an indicator that you can use related to relapse, where if these 3 things are changing, then it can give you a warning that there are problems coming, and we need to be alert to be ready to offer a new treatment. And so these 3 tests are the free light tests, the myeloma protein level, and also the percentage of plasma cells in the bone marrow. And you can see the cutoffs for those are 2, 20, and 20. So that, for example, 20 would be 20% plasma cells in the bone marrow, 20 would be the free light, and 2 would be the level of the myeloma protein in grams, which is in the blood. Now, if you look at kind of the mustard colored line, the line goes up and it says high risk. Those are the patients who are at the 2-20-20 or higher. And so those are the patients who are likely to have active problems with the myeloma, some of them within a few months, or certainly by 12 to 18 months. And so this is the group that are what we call at high risk, and where we can talk about being ready to treat as needed. And as I say, this applies to newly diagnosed, but also for relapse patients, where we need to be ready and prepared to offer a treatment. Now, what about the next generation approaches? I've said that we're not quite there yet, but they're coming very, very soon. And I think it's important for you guys to be aware of what you're going to be hearing about and more discussion about of these next generation tests for diagnosis and for monitoring. And so one of them is mass spectrometry, which is a very, very sensitive test for measuring the myeloma in the blood. And then next generation flow cytometry, which is a test for the bone marrow, but also in the blood, which I'll show you, which is very important. It measures the number of myeloma cells in the bone marrow, but at a very, very sensitive level. It's not at the level of percentages of like 10% or 20%. The most sensitive one I'm going to show you is going to be able to pick up if there's a myeloma out of 1 out of 100 million cells. So in a very, 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 very sensitive testing to see if there's any indication whatsoever of a tiny, tiny level of myeloma. And those two tests right in front of you there are going to be approved most likely by the FDA by early next year, certainly by later next year. And probably both of those will be approved in Europe this fall. So this is another thing that's happening, is that we tend to think America is the best and the greatest, which it's pretty good. But actually, other places are catching up. And in Europe, they are moving much more aggressively to review and potentially approve these tests, which look promising. And so we're used to FDA approval, but actually EMA approval, European Medicines Authority, they are approving these tests even sooner to give access to patients in Europe and also elsewhere in the world. So mass spectrometry, these words you should probably be aware of. The commercial test is going to be something called mass fix. The commercial name for this is going to be Accent. The test is called Accent. And this is the basic test. And so instead of getting an SPEP report once a month, you're going to get an Accent test result. And it's going to tell you how much protein do you have in your blood. And it's going to be at a very, very sensitive level. And if it says that there's no protein, then they will do in the lab, or can what they call reflex, to do the high resolution approach to look in a more sensitive way to see if there's even a tiny amount of protein. And so this is going to be the new technology that you're going to be learning about. The one on the left, the mass fix, which is going to be the routine test, is called MALDI-TOF. The one that is more sensitive, high resolution, is called QTOF. So MALDI-TOF and QTOF. You can see it's very, very sensitive. And so this is going to be changing the way that we understand myeloma. As I was explaining earlier, if you don't have a myeloma protein level and you might be MRD negative by traditional methods, it could be that with these methods, we will pick up the protein. And so it's not like it's gone. It's just like we're not seeing it. As we go down lower and lower, another thing to be aware of is that your immune system is not just sitting there. This is the chart of what's happening to the immune system of a patient over 3 years. And so over 3 years, the immune system is very, very busy. It's producing all these different antibodies that show up as spikes. When you start looking at a very low level, you actually do see lots of these little spikes coming up and then going away as your body reacts to what you encounter in the environment. If you get a cold, if you get an allergic reaction, this patient had an immune disease and was getting treated for that, these spikes come up and go away. And so we have a whole set of new challenges to understand what is going on with the immune system. And is this a spike that's here to stay, or is it one that is part of your myeloma? Now, if you look at if the test is negative, so if you do the mass spectrometry test and you don't find anything, what does that mean for the patient? Well, this has become very, very important. You can see over on the right-hand side, the serum mass fix. If it's negative, which is the blue one, then most patients are going to be staying in remission. And then if you do that plus high resolution, and also the test I'm going to talk about in a minute, if the bone marrow is also negative, these patients are really going to stay in remission. This is going to be what was mentioned by Nupur Raji as sustained MRD negative. And so this is the kind of testing that is going to become more routinely available for you to know, okay, I'm negative with these two tests. This is really, really very promising because it's going to a very low level. The next generation flow, where you put the cells through the cell sorter, You can also do it with blood. And this is really what I would call a major breakthrough, where you can take the blood and then you can use immunomagnetic beads, which is called enrichment, where it attracts the myeloma, and then it really makes the test so much more sensitive, so you can actually pick up the myeloma in the blood. And this is kind of a new concept for myeloma, where we're used to thinking, okay, myeloma is in the bone marrow, we need to have another new bone marrow. Actually, myeloma is in the blood. It's kind of like a low level of kind of like a plasma cell leukemia, where it's actually something where it is actually in the blood. And it is the reason that myeloma is multiple myeloma. So how do you think the myeloma gets to be here, or it could be there? That's because these cells are floating around the blood, and we can measure them. And obviously, this is so important because we want to get those down to zero. So we have a new goal, which is to get those ones that are in the blood, to get rid of them, to get them down to zero. And the first step to do that is to be able to detect them. And so this just shows you those blue lines off to the right, they indicate the sensitivity that we can get using this new immune magnetic bead technique to measure the amount of myeloma in the blood. And we can pick up all these cases with the blue line, which were not picked up with the old method in the bone marrow. And so the lowest was down to 10 to the minus 8. We're talking about 1 out of 100 million cells we can pick up. So just a high level of sensitivity in the blood. And so what does that mean? We're going to be able to pick up that we're doing a fantastic job. And why is this important? Well, the treatments that you're going to be hearing about, so many of them now, the CAR-T treatments, several, the bispecifics, several, are producing deep, deep, deep responses. And so if we can find that the plasma cells are gone from the blood, that the protein is gone from the blood with mass spec, what does it show? Well, that straight blue line there, which means that everyone is staying in remission. And so we have the ability scientifically to pick up that we have achieved our goal, something where the myeloma is at a level where early relapse is much, much less likely. So this is going to be what I call a paradigm shift. So within the next year or two, we're going to be detecting, can we achieve this great outcome or not? And it gives you the ability to be pleased. It also gives you the ability to be upset because you haven't and you need to do more. And so it offers both those options. And so what is happening with the new therapies and with the new testing is that we can get down to the bottom of the iceberg. So when we get regular testing in the blood with SPEP, we're measuring the white part at the top. We need to get down below the water level and see how much myeloma is left with mass spectrometry, with this NGF testing. And we will be able to get down to the bottom of the iceberg. And then we might be able to have a definitive answer where we could say that someone is possibly definitively cured, where that it's so low that we think that if there is a little bit myeloma left, it may be gone, or certainly is going to be gone for quite a while. So the timeline for this testing is by the spring of next year for the mass spec, and similar for the bone marrow myeloma cells. And then that can also be used as a blood test. But this is going to be such a shift in the way that we approach the disease that we're going to need guidelines. We're going to need guidelines for the doctors. We're going to need guidelines certainly for patients to know if you get a test result that's coming back where your mass spec negative and where that NGF test is negative, what does that mean? One of the things about the guidelines is, and you guys will understand this, I think, pretty clearly, is that the NGF the traditional NGF is done with the bone marrow. So you do the bone marrow test, and then you send the sample to the lab. Now, if it's not a good bone marrow, and I'm sure you've had this happen, where when they take the sample, they say, "Oh, we didn't get enough good marrow." What that means is that they have just blood. You know, they don't have the bone marrow sample that they need. So then they send it to the lab, and then it says, "Oh, it's negative." Well, it's negative because there's no bone marrow there. So you need to have guidelines. You need to have guidelines that says when that sample gets to the lab, it's just blood. And so you reject that sample. And then you need to get a proper sample to know if it's going to be MRD negative. And so there are guidelines for the doctors who are doing the bone marrow test. There are guidelines for the lab. When you put the sample through the machine, you need to have a standardized approach. So there's a new computerized method where when it goes through the machine, there's what's called automatic gating. And so rather than a pathologist is saying, "Oh, well, we'll check this or we'll check that," it's all automatic. And then when it gets to the end, there's a software computer program that tells you, "Well, we've analyzed all of this, and this is the final number that we come up with." And so this is what is taking time with the FDA to get the approval for reliable results. But once this comes through, which is about to happen very soon, this is the way that you're going to be getting information. So we could start talking about understanding cure. If there's sustained negativity, I just showed you, if you're negative at 0 out of 100 million, is that true cure? Well, we're going to be analyzing that. But we also know that when you get down really low, there can be a small amount of myeloma, and it can stay there for a long time. And so we're studying to understand, well, why is that? The immune microenvironment is very important. There could be a little bit of myeloma left, but the immune system is holding it under control. And so we will have the ability to study that. And so when we take the sample, it'll be checking for the myeloma. It'll also be checking to see, how does your immune system look? Is it going to be able to control the possibility of regrowth of the myeloma? And so it's going to be a whole new world to know if there's a little bit that is under immune control, which is what we call functional cure, or if it's 0, and is it going to be sustained 5, 10, 15 years? But we need to learn that first before we can even talk to you about it, because we don't know until we have reliable data. And so when you're making decisions, and this came up today, if you want to make a decision, you're MRD negative, and you want to stop your treatment. So the process is the same. Talk to your doctor. I mean, no, Donna's still here, so don't just talk to your doctor. You should talk to your nurse. You'll notice that I have here, talk to your daughter, but I also have down the book, involve your personal support team, which typically will include a nurse. It'll include a number of people that you're familiar with when you go into the center for your testing and your treatment. And what Susie has always been not shy about is to say, if you're not getting the answers to your questions at all, or answers that you can understand well, get a second opinion. And so these ways of making decisions are really unchanged for now. But as I'm going to show in a second, this is probably going to change as well. There's going to be pressure to use other sources of information to help with the decision process. However, I do believe that what's on this slide is still going to be the most important. Whatever source of information that you have, you still need to bring that back. Talk to your doctor, talk to your nurse, and say, okay, I found out that this is really a good treatment, and I went to GPT-4, and it said this is the best one. No, you need to talk to your doctor. You need to talk to your nurse. You need to get a second opinion. You need to work with your local support group. And you need to come to one of these meetings. You need to come to a PFS where you could be sitting beside, and this is something to think about, you could be sitting beside someone who has already taken the treatment that you're thinking of taking. You can chat to them, and guess what? They can tell you what happened. Did it work? What were the side effects? And so I don't think that there's ever going to be a full replacement for in-person. And what you can learn from just meeting people, you can see how that person's doing, and you can get their honest opinion about how much that came from the team that helped them to get that response. How important was that? And make an informed decision. Now, this is the future here. You're going to be offered all these different ways to find information. Now, I'd like to emphasize, I have on the top left here, the International Myeloma Foundation, and there is an active initiative right now to make sure that on the IMF website and on our different resources, the information is electronically available to guide you. And this is what we would call reliable sources. And so the big thing is that you need to get information from a reliable source. And so we certainly hope that we can be considered a reliable source. But there are other places where you can get information. Up to Date is a fantastic electronic database and analysis of every paper that's published on myeloma. Then Humata is another amazing resource for information about myeloma. It's a free web app. And of course, if you want to know about trials, you can go to clinicaltrials.gov. Or you can go to PubMed, which will tell you if there's been anything recently published on the area that you're interested in. Or, and this is the most controversial thing, you could go to an open IA source like ChatGPT 4.0, which is fully updated, and then you could ask the same question to ChatGPT. What's the best treatment for me? Now, when you ask the question, you can instruct it to just get it from a reliable source. So I've given you some of the, so you could say, okay, I want you to answer this question. However, I want you to go to those other places that I've mentioned on this slide right here and kind of summarize that for me. And it can do a good job with that. But if you don't instruct it to use a reliable source, it's just going to go out there and find whatever. So if you're going to use these sources, you need to be very, very sure that the instruction is correct and appropriate. Now, if this sounds too far-fetched for some of you, or maybe all of you, I don't know, even if we choose not to use it, it's going to be out there and it's going to be available, and we are going to have to deal with these sources and the fact that there are going to be searches done where the information is not accurate and is not being well sourced. Okay, so always review with your care team. Even if you go and you get all these different pieces of information, you've got to bring it back to your team, especially with this kind of stuff. So for now, next generation is coming very quickly, but we still have this word next, which is coming next. But the next in this case is actually pretty soon. But the procedures and the processes are pretty much unchanged for now. But we need to be very, very cautious about how we move forward in terms of deciding what tests will be good in your particular case, and how you want to incorporate what I call new knowledge. When all this new information is coming in, how do you want to search for that? And how do you personally want to ask that with your doctor or to get a second opinion? Or how do you want to move forward and evaluate what these things are about and how they might or might not be useful in your case? So as I say here, you need to stay tuned for all of this. So thank you for your attention.
Q&A time, and you can see by now we kind of have quadrants here. So make sure you raise your hands. And do we have some? Up, I see right in front of you. We've got one on this side, Dr. Durie.
Okay.
Hi. Is the mass spectrometry going to eventually take place of the bone marrow biopsy, or are they going to be used in conjunction?
Right. So the mass spectrometry will definitely decrease the need for bone marrow. I mean, okay. And so will the NGF in the blood. That the idea is that we will still need to do periodic bone marrows, but I've emphasized the blood testing because it will really reduce the need for the bone marrow. Because if you've got a negative with mass spec and a negative in the blood in particular, I mean, you can delay the bone marrow. Yeah.
Right here.
All right.
Hi, Dr. Durie. You started this session asking us about the PET scan and the low-dose CT scan. 3 years ago, when I was getting ready to have my first PET scan, I called up different institutions to find out about getting a low-dose CT scan because I believe I read some kind of article from you where you talked about that. I called Cedar up, and Cedar assured me that the PET scan was a low-dose CT. Is there a
That's correct. Yeah. So the PET CT is good. Yeah.
So, I mean, is there a difference in the amount of radiation in a PET scan as opposed to the low-dose CT scan?
Yeah. Yeah, it's both are low actually. They do the low dose screening with the CT. Yeah. Yeah.
Okay.
I don't know what the recent experience is. I asked earlier, Rafat and Nupur, nobody was aware that they'd ever had a whole body low dose CT. So I don't know how is that going in terms of the ability to get that done or to use it, you know?
We have completely moved, at least at Mass General in Boston, we've moved to low-dose CAT scans. It includes all your bones, and the exposure to radiation is very low. Your question about a PET scan instead of getting a low-dose CAT scan, most PET scans in myeloma have a low attenuated CAT scan. And with that, again, your whole body is imaged, and the amount of radiation you get is very similar to what you get with a low-dose CAT scan.
Right. But are you doing more whole body low-dose CT or no?
Doing whole body. We've given up on skeletal surveys. We do not do X-rays anymore. We are mostly doing, our screening is with a myeloma CT survey, and in a subset of patients, we will use either a whole body MRI or a PET scan, depending on the patient.
Okay. All right. So poor Jens Hillengas, he still hasn't gotten his wish. He's the guy who developed the whole body low-dose CT.
Thank you, Dr. Durie. Right over here.
Between the two scans, is one more sensitive than the other?
Oh, sorry.
Between the two different scans, a low-dose CT or a PET, is one more sensitive than another?
Right. So that's an interesting point. They're both pretty sensitive. I would say probably the low-dose CT is probably more sensitive in picking up very early levels of bone destruction, which in some circumstances might be the most important thing to know. So it depends on the circumstance. And so early in the disease, we're very interested to know if there's any evidence of bone destruction. And also at a moment of possible relapse, we're interested to know, is there any evidence of new bone damage? For that, the whole body low-dose CT is pretty good. Now, another kind of question is there any evidence of residual disease? So if you've had a fantastic response, we have a lot of data on that to show that if the PET scan is negative, that is a very good way to sort of reinforce the idea that you've actually achieved MRD negative. And so we have that as part of our guidelines for MRD negative, is to get a negative PET CT scan. So it kind of depends on the question that you're asking. Okay.
Okay, right over here.
Sherry has a question.
Sherry?
Dr. Durie, I remember early on looking at blood results all the time. I just was focused on my M spike.
Right.
And it didn't, other numbers started to move, like my light chains,
Right.
which we weren't really, not knowing what we were doing. All we were focused on was the M spike. So my question is, when you were showing that beta 2 spike
Right.
on one of your first slides, so that test, is it something to pay the beta 2 microglobulin test that I get results every month? Is that something to keep an eye on? Will that start
Yes.
to
So that's the
predict
protein.
it'll move before your M spike moves, maybe? Like it'll start to keep rising?
So that's that spike is that is the M spike, and so that's the thing to keep track of. Okay.
So what is the difference in the test, just the SPEP that gives me an M spike and the test that shows what that beta 2 number is? Because I get an actual test that says beta 2 microglobulin.
The beta 2 micro, that's a completely different test. The beta 2 microglobulin, that gives you different information. Beta 2M, I didn't talk about beta 2M actually, and I'll tell you a couple of things about that. But beta 2M reflects the burden of the myeloma, sort of broadly how much myeloma there is, and also the activity of the myeloma. There have been several registries for myeloma that I've been involved with, and so we decided that we wanted to keep track of the beta 2 microglobulin for all of our patients. And so in a registry, what you do is you capture what the doctors are doing. And so that was so disheartening because we wanted to do a study of beta 2 microglobulin, but most of the patients, the doctor hadn't done the beta 2. The beta 2 microglobulin had actually not been done. Actually, Rafat knows this as part of the Connect registry. 50% of the patients, the beta 2 was never done. And the reason for that, one reason for that is that if the beta 2 is high or low, it doesn't drive a treatment decision. It doesn't tell you that you need to definitely do something different. Whereas the level of the spike, it does. That's a direct reflection of the myeloma. And so we want to see the spike coming down. And then in addition to that, we need the free light to make sure there's not a change in the free light, where if the spike's coming down, sometimes there can be a buildup on the free light. So you do need to have both of those to be sure.
Straight back, Dr. Durie.
When the mass spec is approved, who will get it? And when is it done? And where is it done? And is it expensive?
All right. So it's cheap. I'll tell you this. The second part is it's cheap. Well, it's intrinsically cheap, but there's always the potential for markup, But it is basically very cheap. And so the idea is that it would be structured so that it could be done at your local large center. So mass spectrometry is used at most large centers for a variety of things. It's used to track the blood levels of a lot of different medicines, for example. If you're taking the digoxin or you're taking a different, you can track the level using mass spectrometry. So most large centers, like the Cedars over here, they've got a bunch of mass spectrometry machines over there. What you need is the kit and the antibodies and things so that you can use the mass spec for the myeloma protein. Okay, so there's a kit, and so the company, the binding, well, they're here actually. There's the binding site, and the company that's involved with them called Thermo Fisher. They will be basically selling the kits and also the machines, I think, to any large center who wants to set up. And some people here may remember where we used to send the free light all to one place, and then a lot of centers started doing it themselves. So it's going to be the same kind of a deal. there's certainly the capability that this can be done at any large center. Right now, you can get it done by sending samples to the Mayo Clinic, and there's a few other centers that you can get it done. I think that one of the commercial labs has also set up to run the mass spec, actually. So it can be, so each center will decide if they're going to do it themselves or they're going to send it to someone to get it done. But what's happening, and what's happening actually at the Mayo Clinic, is that they're going to switch from one to the other. So you go in 1 month and it's your SPEP, and you go in the next month and it's going to be mass spec. And so that's why I'm saying we need guidance about this, and you need to be prepared that sometime between now and spring or late spring, the labs are going to switch over. And there's a big motivation for the labs to switch over because the SPEP is very expensive in the sense that you need people to set it up. You need people to set up the SPEP, and also you need people to interpret the SPEP, to look at those, and then set the guidelines to calculate what is the amount of the protein level. And so the switch to mass spec will reduce the lab costs substantially, and the need for lab personnel. And so there's going to be a high motivation. And so at Mayo Clinic, for example, they're really motivated to switch. So this is going to happen. As soon as it's approved, there's going to be a high incentive to switch. So as soon as there are guidelines and details, we'll certainly be trying to provide those so that everyone is aware. They haven't finalized what the report is going to look like. It would be good if I could come up here and show you what is that report going to look like once they implement the test. And so we're going to be doing that once we have it. All right.
More questions? Yes, you have questions, and these doctors have answers.
Thank you, guys. It's getting a little bit later, but I appreciate your attention.
Okay.